Assalamu alaikum. Welcome to this session on evidence-based guidelines of pediatric ocular problems. We have always been wary of following what the West says, but वही हमारे पास एक चीज़ होती है which we have to follow. Fortunately, for the past decade, we now have a lot of data which shows about people. So this session is going to be chaired by President OSP Central, PS Meher Saab. Sir, I would want you to come and be on the stage. Thank you. I would also want Professor Zia Saab to come and sit here. And I would want Professor Salim Akhtar Saab, who has written a book on ophthalmology for medical students, which is very popular, to come and sit here. Sir, आप भी आ जाएं आगे. है सर जगह? सर इसीलिए So as I was saying that हमारा usual एक norm जो रहा है, we've been following guidelines that the West produces, and now there's a lot of data which shows that Caucasian population is not the non-Caucasian population, and for the last decade we've been documenting things better, we've been seeing things better, and we wanted that we should have pediatric disease guidelines which are Pakistani tailored and Pakistani based and regional based. Keeping that in mind, we have come up with this small effort. I would want to thank the people jinka data humne jhanjoda hai, which includes the editorial board, Dr. Seema Kuyum, Dr. Surat Nurani, Dr. Khurram Mirza, जिनके पास I think ROP का सबसे बड़ी encyclopedia इनके पास है. I would want to thank all of these people and the authors for and the guidance given by Shafiq Saab and Zia Saab regarding this. And finally, we have a Pakistani-based pediatric ophthalmology guidelines. So big cheer to and big thank you to the people who've supported us and done all of this. The first presenter would be Dr. Samreen Jamal, who would be doing the guidelines on retinoblastoma.
I am Dr. Samreen Jamal, Senior Registrar at Jinnah Hospital, Lahore. As already said, the editorial board consists of these three people, and the contributors for the retinoblastoma guidelines are these people. The regional center, you all know that there are many in Karachi, in Lahore. These are in Pindi, Multan, Peshawar, and Hyderabad. Background, I will not go in the detail of the background. You all know that. And the screening protocols, we have to make the screening protocols for the pediatric doctors and for the ophthalmologist also. For the pediatrician, the first to life of the child, he or she should visit the doctor, and the pediatrician should see the red glow with the direct ophthalmoscope and should see the corneal reflex with the torch and should see the Hirschberg whether the eyes are central or not. And he should know when to refer to us. When there is strabismus, when there is leukocoria, when there is abnormal red reflex. And any child with a family history of retinoblastoma, he or she should refer to us. And as ophthalmologists, what we should do for the screening is that we should admit that patient, do the examination under anesthesia, refer to radiology for MRI, refer to oncology for systemic evaluation, and categorize the patient according to these information. This is the flow chart. You can go through this in your handbooks. This you see is a retinoblastoma referral form, right? काफ़ी ऐसे हमारे ऑप्थमोलॉजिस्ट भी हैं जो प्राइमरी सेकेंडरी में काम कर रहे हैं, टर्शरी हॉस्पिटल्स में नहीं हैं, वहाँ रेटिनोब्लास्टोमा की फैसिलिटी नहीं है. प्लीज़ एक है मैसेज कि सीटी मत करवाएं रेटिनोब्लास्टोमा के पेशेंट्स में, प्लीज़. ठीक है, काफ़ी हमारे पास पेशेंट्स ऐसे रेफ़र होके आते हैं कि जिनका सीटी हुआ होता है, रेटिनोब्लास्टोमा लेबल होता है. ओके, दैट्स गुड कि आपने रेटिनोब्लास्टोमा डायग्नोज कर लिया ऑन द बेसिस ऑफ सीटी, मगर CT से सेकेंडरी कैंसर्स आपको पता है कि रेटिनोब्लास्टोमा में होने के बहुत ज़्यादा चांसेस हैं. MRI की फैसिलिटी नहीं है, आपको सस्पिशन है तो रेफ़र कर दें, किसी टर्शरी में रेफ़र कर दें. पेशेंट को इधर उधर ना भगाएं प्लीज़, क्योंकि हमारे पास इतनी ज़्यादा विंडो नहीं होती है इनको ग्रुपिंग और फिर आगे ट्रीटमेंट करने के लिए. दिस इज़ द EUA रिपोर्टिंग फॉर्म. The treatment guidelines depends upon the grouping and staging of the disease, right? You all know there is focal therapy, intra-arterial enucleation, and radiotherapy. In focal therapy, there is laser cryo, intravitreal chemotherapy, therapeutic agents, and subconjunctival and subtenon chemotherapeutic agents. जो हम use करते हैं वो मेल्फ्लान और टोपोटिकैन है, राइट? अच्छा, अब जो है इस सारी टॉक में सबसे इम्पॉर्टेंट बात जो आपने याद रखनी है वो ये है कि इंट्रा आर्टीरियल जो है अब एक ऐसी डोमेन है या ऐसा ट्रीटमेंट मोडेलिटी है जिसको आपने आगे देखना है और उससे काफ़ी आई प्रिजर्वेशन हो रही है. अगर किसी भी बच्चे में कोई भी आपको लगता है कि परसेप्शन ऑफ लाइट है तो ग्रुप E है, परसेप्शन ऑफ लाइट है, इन्यूक्लिएशन की तरफ नहीं जाएं, ठीक है? उसको आप प्रिजर्व कर सकते हैं इंट्रा आर्टीरियल के साथ. दिस इज़ ऑल द डिटेल के ग्रुप A के अंदर ट्रीटमेंट में क्या करना है, फॉलोअप पे क्या करना है, ग्रुप B में क्या करना है, C में और D में, ठीक? ग्रुपिंग्स होती हैं इंटरनेशनल इंट्रा ऑकुलर रेटिनोब्लास्टोमा क्लासिफिकेशन के मुताबिक. फॉलोअप कब करना है? एक्टिव डिजीज़ है जिसमें आप कोई फोकल थेरेपी दे रहे हैं तो 3 वीकली उसको फॉलो करना है लाजमी. इनएक्टिव डिजीज़ हो गई है तो आपने इसके लिहाज से जो डिटेल सारी लिखी हुई है उसके लिहाज से उस तरह आपने फॉलोअप करते रहने हैं. और एनुअल फॉलोअप, एनुअल एग्जामिनेशन करना है आफ्टर 9 years. Growing emphasis on the organ preservation, vision salvage, and minimizing long-term treatment complications. Treatment decisions depend on the extent of the disease, the patient's age, and assess to the specialized resources. Thank you so much.
Thank you, Dr. Samreen. So the idea is to have standardization ताकि अगर कोई प्राइमरी और सेकेंडरी केयर हॉस्पिटल से कोई पेशेंट आ रहा है तो रेफरल फॉर्म्स भी हमारे स्टैंडर्डाइज्ड हों. It is easier to follow, it's easier to keep a track of such things, and it's easier to implement. The next presenter is Dr. Fiza Azhar, who's going to come and talk about the glaucoma guidelines.
Bismillahirrahmanirrahim. Assalamu alaikum everyone. I'm Dr. Fiza Azhar, consultant pediatric ophthalmologist at Mughal Eye Trust, Lahore. I would like to thank Professor Seema, Professor Ali Ayaz, and Professor Surat for trusting me with this job. I would like to acknowledge the contributing author, especially Professor Sarfaraz Hussain Saab. He's here with us. Thank you, sir, for your valuable input. And I would like to encourage my trainees at Mughal Eye Trust, Lahore, who have contributed and done a hard work to prepare these guidelines. I would not go into details because all of you have the guidelines in front of you in the print form, and we soon plan to upload these guidelines on the website of OSP Lahore. So you can refer to these guidelines if any detail is wanted. I would just briefly go through. Primary congenital glaucoma is the most common non-syndromic glaucoma in infants, and its incidence is 9 times higher than in Caucasian population, depending upon the consanguinity and genetic predisposition, especially in Pakistan. We all know that it's a developmental anomaly of the trabecular meshwork. 65 to 80% of primary congenital glaucoma cases are bilateral. Male to female ratio is 3:2. Classic triad of photophobia, blepharospasms, and lacrimation, which, when left unchecked, can lead to these ocular anomalies and globe malformations. Classification, according to 9th consensus report of World Glaucoma Association 2013, childhood glaucoma is divided into primary and secondary, which is then again divided into acquired, non-acquired, can be ocular or associated with systemic associations. Screening protocols are important. Screening protocols should be followed by pediatricians, by ophthalmologists, by pediatric ophthalmologists, by nurses or local healthcare providers. At every well child visit, that is at birth, and routine vaccination visits. अब इन visits पे उन्होंने देखना क्या है? Look for gross examination, excessive lacrimation, photophobia, large cornea, and ophthalmos. Gross visual acuity should be age appropriate, and always perform distant direct ophthalmoscopy. Even a medical officer or a house officer should have a pocket direct ophthalmoscope to screen for reflexes. Referral criteria. This is important. Urgent referral to an ophthalmologist is to be made if visual acuity is not corresponding with age. There is blepharospasm, photophobia, lacrimation, corneal enlargement, corneal haze, enlargement of the globe, dull red reflex. Do not forget other causes of lacrimation, photophobia, or discharge, which is congenital NLD obstruction, simple megalocornea, corneal dystrophy, corneal abrasion, metabolic disorders, conjunctivitis, disc coloboma, and other retinal and disc anomalies, and birth trauma. Management protocols will briefly go through. An outpatient department exam aims to gather as much information as possible to determine if an examination under anesthesia is warranted. These things should be taken into account while taking history, gross examination, visual acuity testing. This should be age appropriate for pre-verbal and verbal children. Slit lamp examination, if the child allows a slit lamp examination, you must do, and take corneal diameters. Normal values and abnormal values are mentioned with respected age, anterior chamber depth, and intraocular pressure. Mean intraocular pressure for Pakistani Caucasian population is 12 plus minus 3.74 millimeters of mercury, and it can be measured by eye care, tonopen, or Goldman applanation tonometry. Cycloplegic retinoscopy is mandatory. Look for myopic shift. Fundus exam, not only to document cup to disc ratio, but other retinal anomalies. Accurate corneal diameter, intraocular pressure measurement, thorough interior and posterior examination, and gonioscopy should be performed under anesthesia. Some ophthalmologists prefer using oral chloral hydrate. There's nothing wrong with it, but you should know the right and appropriate dosage. Recommended dosage is 50 to 75 milligrams per kg body weight. It has the advantage of not significantly lowering IOP, however, requires monitoring until the child is fully awake. Common side effects include nausea, vomiting, irritability, and serious side effects include respiratory depression and bradycardia. So whenever you decide in the outpatient department that you want to give chloral hydrate, you must have an emergency backup available. You should have your emergency medical officer who can tackle these emergencies, and proper emergency care should be available in that very facility. Counseling is the most important part. You must tell the parents that it's a treatable disease only if it is diagnosed early and early intervention is done. Management options should be thoroughly explained. Parents should be told that if one procedure fails, the child may need second or third procedure. Examination under anesthesia. We have devised a very detailed EUA performer, which is available in the guidelines. I would just share it here briefly. These are the equipments. Corneal diameter must be measured with calipers, and white to white diameter should be taken, and both vertical and horizontal diameters should be measured. Intraocular pressure should be measured right after the child stops moving post inhaled anesthesia and before intubation to avoid artificially low readings. Use of eye speculum elevates IOP by average of 4 millimeters of mercury. So you should try measuring intraocular pressure without speculum. The time when the pressure was recorded should be noted and mentioned and documented. For example, intraocular pressure in the right eye 14 and left 15 millimeters 10 minutes into anesthesia. It is very important to mention कि anesthesia दिए हुए कितना time हो गया. And same tonometer should be used at every examination. Handheld Goldman applanation tonometer is the gold standard. This is the EUA reporting form. If you follow this, I don't think that you can miss anything in the examination. Treatment, what and when to do. Medical treatment is only for gaining more time, for temporizing while awaiting surgery, given preoperatively to decrease intraocular pressure to clear the corneal haze and to avoid sudden decompression. Punctal occlusion should be done, performed at least 1 to 2 minutes after drop instillation. These are the groups of drugs you can use for medical treatment. Alpha 2 agonists are strictly contraindicated in children under 2 years of age. Surgery should not be delayed in an attempt to achieve medical control of IOP. What surgery you are supposed to do? If there is clear cornea, age is less than 3 years, go for goniotomy. There is difficult angle visualization, age is less than 3 years, go for trabeculotomy. Child is older than 3 years, after a failed primary procedure, or you want to combine trabeculotomy with other procedure, go for trabeculectomy. Post-operative care, routine post-op, taper steroids according to the status of the bleb. A healthy functioning bleb will look diffuse, avascular, and slightly elevated. Then what metabolites you can use? I will just quickly go through acute post-operative complications. Most common is the hypotony. How to manage it, detail is given in the guidelines. You can manage it conservatively, but surgical and invasive management is needed when there is a severely shallow AC or there is lenticulocorneal touch. You can reform the anterior chamber. You can revise the scleral flap sutures and surgical repair of bleb leak. In refractory cases, you can do GDDs and cyclodestructive procedures. Then MIGS is getting popular because it's conjunctival sparing. Rehabilitation and follow-up. IOP monitoring should be done quarterly, at least for 2 years post-surgery, and every 6 months annually for life. Important to tell the parents that IOP monitoring will be done for life. Cycloplegic refraction, do not ignore the refractive errors. This can, you might have done an excellent surgery, the IOP would have been controlled, but the child would still be amblyopic because the refractive errors were not addressed. Thank you.
Is Dr. Sidra Jabin on ROP guidelines.
I'm Dr. Sidra Jabin and I'm working as Associate Professor in Rawalpindi Medical University, Holy Family Hospital. Today I will be presenting evidence-based, context-specific guidelines for ROP treatment and screening. Before starting my presentation, I would like to extend my heartfelt acknowledgements to Dr. Surat Noorani, my very dear and respectable mentor, and Professor Khurram Mirza for their continuous guidance and support during the process of making these guidelines. It was only possible with their help. It is not possible to cover all the guidelines in such short duration. I will cover just main important points. As we all know, ROP is the most common preventable cause of childhood blindness worldwide. And world has already been through 3 epidemics of this potentially blinding disease. With currently, world is going through 3rd epidemic, which has predominantly affected lower and middle income class countries, especially Pakistan. A 2023 WHO report has stated that Pakistan has one of the highest preterm birth rate globally, sitting at 14.3%, and with current survival rate at 71.5%, hundreds and thousands of babies are at risk of developing ROP every year. So this heavy burden of the disease means that we are currently seeing 3rd epidemic in Pakistan. But along with these high burden of disease, we have other intrinsic challenges as well. For example, ROP screening services might not be available in peripheries. There is lack of communication between ophthalmologist and neonatologist, and they might not getting proper referral. Some of the infants might not be referred at all, some referred very early while they are still in window period, or some referred very late with advanced disease at presentation. And variable neonatal care resources, meaning that large and more mature babies are developing ROP. So all of these challenges required us to come up with context-specific ROP guidelines. So these guidelines are just not a piece of document. These are a lifeline for these babies who have survived prematurity and now depend on us to preserve their vision and prevent lifelong disability. Objective of the guidelines was very simple. It was to make a context-specific standardized national ROP screening and treatment guidelines, and to improve neonatology and ophthalmology coordination. As clinical experience has grown for ROP, we see large and more mature babies developing ROP. So our eligibility criteria for screening is held at 36 weeks of gestational age and birth weight of 2,000 grams. And additional infants with unstable clinical course might also be considered for screening. All premature infants must be seen at 4 weeks chronological age, irrespective of the gestational age at birth. This rule is introduced to reduce any confusion in neonatologists and to improve referral. It will also prevent very early or very late presentation. Indirect ophthalmoscopy with indentation is the gold standard for examination. For staging the disease, retina is divided into 3 zones centered around the disc. Zone 1 being the posterior pole, Zone 2 between Zone 1 and Zone 3. Zone 2 is further divided into Zone 2 posterior and Zone 2, and Zone 3 is the remaining temporal crescent. Disease severity is staged from stage 0 to stage 5. Stage 0 is no ROP, stage 1 is demarcation line, and stage 2 is ridge. Stage 0, 1 and 2 usually resolve without treatment and are kept on follow-up. Stage 3 is extraretinal fibrovascular proliferation. This is where things get serious and require treatment. Stage 4 and 5 are retinal detachment. Additional danger signs are presence of plus disease, which is vascular dilatations in more than 2 or more than 2 quadrants. For stage 0, 1 and 2 disease, follow-up is recommended. For zone 1, follow-up is done at 1 week interval, and for zone 2, follow-up is kept at 1 to 2 weeks, and for zone 3, follow-up is done at 2 to 3 weeks. Standard documentation ensures continuation in treatment and management, and can also be used for research purpose and national registry later on. Gestational age, birth weight, and chronological age at presentation must be documented, along with additional risk factors such as oxygen requirement, neonatal sepsis, respiratory distress syndrome, etc. Examination findings must be documented as zone and stage of the disease, presence or absence of plus disease, along with future plan to treat or follow up. Indication of treatment include aggressive ROP, which is aggressive posterior ROP renamed, any stage in zone 1 with plus, and stage 3 in zone 1 without plus. Stage 3 in zone 2 with plus, treatment is given, and for stage 3 zone 2 without plus, treatment can be considered, especially for high-risk babies and babies who are likely to not come back for follow-up. Available treatment modalities include lasers and anti-VEGF. Laser is done under general anesthesia or sedation. It is a lengthy procedure. It might not be available everywhere. For posterior disease, large area of the retina needs to be ablated and can lead to peripheral visual field defects along with cataract and anterior segment ischemia. Its onset of action takes about 1 to 2 weeks. While anti-VEGF is freely available, it is a 5 minutes procedure done under topical anesthesia and can be done in very preterm babies as well. It has rapid onset of action, and plus disease starts resolving within 48 to 72 hours. So the real debate is which treatment is better. Each laser and anti-VEGF both have their own pros and cons. Laser is the definitive treatment. It has no recurrence rate. It is preferred for zone 2 disease and for late reactivation of the disease and for persistent avascular retina, while anti-VEGF is preferred for very preterm babies and for aggressive ROP and zone 1 and zone 2 disease, zone 2 posterior disease. For post-treatment follow-up, after laser, follow-up is done at 1 week to ensure adequacy of the laser treatment, and then 2 to 3 weekly interval until there is regression of disease. For anti-VEGF, first follow-up is done at 48 to 72 hours to ensure, to check intraocular pressure, to ensure the regression of the disease had started, and then 2 to 3 weekly interval until either retina is completely vascularized or the child reaches the age of 65 weeks post-menstrual age, at which stage rescue laser can be applied if there is persistent avascular retina. Screening is stopped when vascularization has reached zone 3 or laser ablated area. Key take-home message is ROP will become truly preventable with timely screening and treatment of the disease. Remember, screening safe site. The picture has been shared with consent. Thank you so much. That's all from my side.
The next presenter is Dr. Javeria Tariq, who's going to give guidelines on pediatric cataract.
Bismillahirrahmanirrahim. Assalamu alaikum. I am Dr. Javeria Tariq, consultant from Sardar Trust Eye Hospital, Lahore. And today I'll be representing pediatric cataract guidelines, the screening and management. First of all, I would like to thank the editorial board, Professor Seema Qayyum, Professor Muhammad Ali Ayaz Sadiq, and Professor Surat Noorani, and contributing authors, which is the Sardar Trust Eye Hospital team, Dr. Insha, Dr. Javeria, myself, Dr. Shahzeb, and Dr. Irfan Ali. A little bit of overview. What we will be discussing today is the rationale and background of the problem, the screening and referral criteria, recommended instruments, pre-op evaluation, and we'll be addressing queries like what to operate, when to implant the IOL, what surgical considerations should be made, and how the post-op evaluation, follow-up, and visual rehabilitation should be done. So a little bit of rationale of the problem. 200,000 children in the world are blind due to cataract. And every year, 20,000 to 40,000 children are born with cataract. So this is huge. Moreover, it is an enormous problem in countries like ours, which are developing countries, in terms of human morbidity, economic loss, and social burden. So the need for pediatric cataract guidelines stems from the fact that the blindness is preventable, and timely detection can prevent a drastic sequelae of the disease. Moreover, currently there are no guidelines for screening and management of congenital cataract in Pakistan. So what is the screening criteria? It is recommended that all newborns must have a red reflex screening at birth, followed by 1, 3, and 6 weeks. Moreover, all preschool children will be assessed in the community at 3 and 5 years of age, while an ophthalmologist will do a comprehensive eye exam at 3 months and 1 year of age. So who should be referred to an ophthalmologist? Urgent referral to an ophthalmologist is mandatory if there is presence of any lenticular opacities, if there is absence of red reflex, or there is presence of leukocoria, strabismus, or nystagmus. This is the list of instruments which are required for a pediatric ophthalmology setup. Next, what are the things that need to be seen preoperatively? First and foremost, detailed history should be taken, especially about developmental milestones of the children, pedigree, family history of any health problems, cousin marriages, and gestational history of infections, exposure to toxin, radiations, and drugs. Next, it is very important to do age-related visual acuity testing of the children. In preverbal children, it can be done by forced preferential looking techniques like Teller acuity cards and Cardiff cards, or by checking fixation following of the children or aversion to occlusion of the eyes. And in older children, it can be done by HOTV matching these symbols, tumbling ease, and matching game or identification of symbols or letters. Next, it is also important to check the intraocular pressure of all children, corneal diameters, detailed anterior and posterior segment examination should be done, and if the view of the fundus is hazy, a B scan should be ordered. Now, next, what lab test should be advised? We should all know that not all cataracts require aggressive testing. Tests are not required if the cataracts are unilateral or if the cataracts are bilateral with positive family history, or the cataracts are bilateral but there are no associated systemic comorbidities. However, the lab testing should be done when the cataracts are bilateral and there is no family history, or the cataracts are bilateral and the child has systemic signs and symptoms of associated comorbidities. What tests should be advised? Urine test for reducing sugars, amino acids should be done, and serum levels of calcium, phosphorus, glucose, and galactokinase levels should be checked. Torch screening and VDRL testing should also be done. Now, the next question is what to operate. Just like we discussed, not all children require aggressive lab testing. Not all cataracts require a surgery. So only those cataracts which are visually significant, they require surgery. In preverbal children, any dense cataract which is central and is of 3 millimeters or more is visually significant. And if the view of the macula is hazy, or if the child has abnormal visual behavior or has an aversion to occlusion of the good eye, that is visually significant and that requires surgery. For verbal children, any opacity which is causing a decrease in quality of life or a reduction in vision to 20/40 or 6/9 or worse with amblyopia therapy, that is significant. Or if the vision is good, 20/20 or 6/6, that is normal, but it decreases to 2 lines on glare testing, that is significant and that requires a surgery. So summarizing, in unilateral cataracts, first and foremost, we should exclude trauma. Next, check 3 things. Assess the visual function, size of the cataract, and do a fundus exam. If the visual function is abnormal or falls on glare testing, that requires surgery. If the size of the cataract is more than 3 millimeters, that requires surgery. And if the macula is not visible, that requires surgery. For bilateral cataracts, since they are associated with systemic associations and they are hereditary, so it is important to take a family history of cataract, consanguineous marriages, fits, or antenatal infections. And accordingly, labs should be ordered, including torch profile, VDRL testing, and urine for reducing sugars. And if the torch is positive, a multidisciplinary approach should be is required. Now, after determining what to operate, we should know when to operate. So let us have a look at the evidence. Bush and Strager found that if the surgery in unilateral cataracts was performed from birth to 6 weeks, the visual outcomes were better. But if the surgery was delayed to more than 6 weeks, the visual outcomes were worse. So it is recommended that the optimal age for unilateral congenital cataract surgery is 6 weeks of age, or as early as possible if it is detected after 6 weeks. And for bilateral cataracts, Lambert and co-workers, they found that if the surgery was done from birth to 10 weeks, the visual outcomes were better. But if the surgery was delayed to beyond 10 weeks, the visual outcomes were very poor. And Birch and co-workers, they found a bilinear relationship stating that if the surgery was performed between birth and 14 weeks, the visual outcomes worsen as the age increases. And after 14 weeks, the visual outcomes get independent of age and upward. So it is optimal to perform surgery for bilateral cataracts at 6 weeks for the first eye, and at 8 weeks for the second eye, and as early as possible if it is detected after 6 weeks. Regarding biometry, it is important that the keratometry measurement should be done without a speculum. And immersion technique should be preferred to contact technique because of high predictability for IOL power calculation. Now, what IOL power to choose? Since the eyes of the children are continuously growing, a myopic shift is expected. So immediate postoperative hypermetropia is desired. In unilateral cataracts, target hypermetropia equals hypermetropia in the normal eye, while in bilateral cataracts, target hypermetropia equals 6 minus age of the patient. Now, the next question is, what type of IOL should be chosen? 93% of the pediatric cataract surgeons are using hydrophobic acrylic IOLs because of high biocompatibility, less chances of postoperative inflammation, less chances of posterior capsular opacification, and need for a smaller incision. So typically, 1-piece lenses are used for in-the-back fixation, and 3-piece lenses are used for sulcus fixation. The beneficial effect of heparin is questionable. While in uveitic cataracts, it is found and the evidence shows that heparin-coated PMMA IOLs decrease postoperative inflammation. Next question is when to implant the IOL. So we have two trials. In infant aphakia treatment trial, it was found that if IOL implantation was done before 6 months of age, it showed more complications, reops, and glaucoma, as compared to if the children were left aphakic. While the toddler aphakia pseudophakia study showed if the surgery was performed before 7 months, it was associated with more complications, reops, and glaucoma. However, it was safe to perform surgery from 7 months to 2 years of age. So it is agreed that the IOL implantation should not be done before 12 months of age. Next, however, it is interesting that in a recent meta-analysis, it was found that the glaucoma risk after surgery is actually associated with surgery in the first month of life and any additional surgeries done. It is not associated with primary IOL implantation. Now, what surgical consideration should be kept in mind? Adequate pupillary dilatation should be done. The use of heparin and TPA has been found to be beneficial, and adequate size of capsulotomy is 4 to 5 for an optic diameter of 5.5 to 6. Anterior capsular polishing should also be done. Primary posterior capsulotomy is mandatory since there are 100% chances of posterior capsular opacification. It should be done up to 8 years in normal and normal kids, and also 8 years for mentally challenged patients. Role of steroids at the end of the surgeries. The steroids are also beneficial to be given intracamerally or subconjunctivally. It is of utmost importance to note that all wounds in children should be sutured, and suturing can either be done with a nylon or vicryl suture. Postoperatively, steroids, antibiotics, and mediatics are to be given. Follow-up is of utmost importance. Initially, it is 6 weekly, followed by 3 monthly, and then 6 monthly. It is important to note that the follow-up has to be lifelong. Now, what to see on follow-up? Wound integrity, signs of inflammation, astigmatism, refraction, centration of IOL. And again, it is very important to know that glaucoma screening should be done in all children who have had cataract surgery done for life. Visual rehabilitation can be done in unilateral cataract patients with aphakic contact lenses, while aphakic glasses or contact lenses can be used for bilateral cataract patients. Bifocals are to be given to all the patients who are 3 to 4 years old or older. And finally, the patient should be counseled in detail. And at the end, I would like to say it is very prudent to intervene in pediatric cataract patients at the right time. But even with timely intervention, the final visual outcome depends upon timely management of amblyopia and regular lifelong follow-up. Thank you very much.
Thank you, Dr. Javeria. Because of paucity of time, I'm just going to do it quickly. Dr. Asma for refractive error guidelines.
I'm just going to run through this because pediatric refractive errors is it's the important thing, and also it's the bread and butter for the ophthalmologist. Either it's a pediatric ophthalmologist or a general ophthalmologist or even a trainee doctor. It's the bread and butter. That's what I have learned. So it's very important to what to prescribe, when not to prescribe. And presenting these guidelines is actually living like a dream of Dr. Seema Qayyum, and I'm living through it, alhamdulillah. All praise to Allah we have managed to reach here. So this is the most important visual cause that needs to be corrected, and we can actually make a difference by knowing what to correct and when to correct. The most important concept to understand for the refractive error is the emetropization that takes place from the time of birth till the age of 6 years. Infants are hyperopic plus astigmatic, and this reduction in hyperopia occurs till the age of 6, and myopia eventually emerges after that. So newborn has a refractive error of +2 to +3. Preschool, there is a rapid emmetropization, and school age onset is myopia, and teens have progressive myopia. So these are the refractive errors which we are going to look at the specific age when a child walks into our clinics. So these are just the epidemiology and the risk factors. Kids usually do not complain about the blurring of vision. So this generally we get an idea either with the head tilt or a squinting or watching things closely. And though we should have screening protocols for a newborn, for a preschooler, and at the school age, but unfortunately for the most of the people, these practices have not been in place. However, we should have these things. So this is a table which has been provided to you in your booklets. We can all go through this, what age, which error is the normal, and how this physiological changes takes place. So the gold standard remains is the cycloplegic refraction. Cyclopin, tropicamide, or atropine are the drops that we usually use. We all know the strengths, and cycloplegia is strongly recommended because we belong to the race where there's dark irises, and this has to be done. We know that installation of the drops, it's safe to occlude the nasolacrimal duct so that we do not have a systemic absorption of cyclopin, and we avoid using atropine until and unless it is badly needed, because that can have systemic side effects. And usually we do not know that the child walking to our clinic is actually a normal child or not. He might be having some fits, or he might have some other developmental issues that might have been masked. So what to prescribe thresholds are hyperopia with esotropia. We always give a full correction. Myopia more than 1 diopters, we do correct it. Astigmatism more than 1 diopters, although this varies by the age, and anisometropia of 1 to 3 diopters depending on the type. Because astigmatism, meridional astigmatism, especially at the younger age, that needs to be corrected. We do not, if we leave that to like khud hi theek ho jayega, there is nothing that jo khud hi theek ho jayega hota hai. Actually, it is something which is uncorrected, which we see if a child of 9 years is having a -9. So this was actually the one who is not corrected. Wo ek din mein nahi hua hota. The management strategies are the glasses are the mainstay of treatment. Polycarbonate lenses are preferred. Myopia control ke liye we do use atropine and ortho-K and DMS. This is not a forum to talk about these things, but yes, the guidelines do acknowledge these modalities as a methodology of controlling the myopia progression. And amblyopia is definitely a thing to treat whenever we are talking about refractive errors. First of all, the glasses, the first step is the glasses, then is the patching or penalization. So glasses, that is the one thing that is, we have to do. So this is a table which actually gives you the actual measurements for like what hyperopia in which age needs to be corrected, and what are the, like especially if there is a squint present with that, and at what age we need to give that. And astigmatism also carries a higher risk of amblyopia, so astigmatism also needs to be addressed in addition to hyperopia in a younger child to prevent amblyopia especially. So the special considerations about the aphakic or the pseudophakic correction is that the immediate correction should be done. Developmental delay may also, we should prescribe the child glasses as early as possible. Whenever we can, we should give a child with a developmental delay a glasses wherever we can. And ROP also has a higher risk of myopia, so we should also monitor all the patients with ROP for progression of for myopia in all the ages. Even if they didn't have ROP, if the child was premature, we should tell the parents when we are discharging from the follow-up of ROP that please keep this child on a follow-up of an ophthalmologist for any type of glasses he may need, although there's no family history. And esotropia, we treat the hyperopia of more than 1.5 diopters. So follow-up is definitely indicated, either it be 3 to 6 months or 12 months or once in a year. But whenever we are doing an amblyopia therapy, we should do a follow-up on a regular basis, like 6 to 8 weeks. So this is the flow chart which has been made and is being given in the guidelines or the booklet we have been provided. You can all go through it. And documentation is very, very important. So future directions are AI-based predictions, genetic risk scoring, and impact of digital screen exposure. And guidelines obviously will need to be updated later on, inshallah. So that's all from my side. Early correction prevents lifetime visual impairment. Standardized guidelines are essential, and they are critical for India and Pakistan and other developing countries. Thank you so very much, sir.
Thank you. Thank you very much, Dr. Asma. So all the participants, there are handbooks of this pediatric guidelines at the back. If you want to have a copy, you can. I would want President OSP Central to come on the stage, and we would want Dr. Seema Qayyum also to come on the stage with Shafiq Saab, so that